So several people have already asked about adjuvant therapies and are we studying this, and obviously the answer is yes to that. One question is, for adjuvant therapy or postoperative therapy, we have a population of patients with a better prognosis. Obviously, a lot of patients, more than we would ever hope, have their cancer recur, but some are cured. And right now, we don't really have a paradigm for how long is the best to treat. So my questions are really about do you know what the duration of these therapies is when given in the adjuvant setting? 1 year, 2 years, longer? And should we have much concern about toxicities, small but potentially long-term, at least with the immune checkpoint inhibitors? And I don't know if drugs like the CTLA-4 inhibitors would lend themselves to early stage disease where toxicities could be a real issue in a population that may already be cured. So I'll start with you, Matt.
Sure. It's an important question. It's one that we don't have a great answer for. I think amongst the things that we don't know is who's going to benefit. We don't know who needs it. For example, there's some patients that are cured with surgery or chemotherapy alone and don't need more therapy. And we don't have the ability to predict who might have side effects. And we don't have the ability to monitor response as it's ongoing. So there's a lot of open questions that are important. But I think those details are important, but the overarching concern is that the vast majority of patients with early stage lung cancer recur. And the majority of those patients will unfortunately die from their cancer. And so that challenge, I think, overcomes the uncertainty of trying to identify which individual patient might best benefit. I think the paradigm in adjuvant therapy overall has been you treat as many patients as is safe, knowing that some of them don't need it and some of them won't benefit. But we do it because of those small fraction of people who are cured. And that's the goal. So I think that it's critically important that we try and better understand who's going to benefit, who needs it, how do we monitor response. But I think that the real driving principle is that, unfortunately, outcomes for patients with early stage lung cancer are not as good as we'd like. And so that, I think, is what drives the need to try these therapies even without all the answers for the moment.
Right. Any other thoughts there?
Yeah, I agree. We have a cancer with very high risk of recurrence and a lot of suffering when that occurs. In contrast, our treatment, at least when we're talking about the Pd-1 and Pdl-1 inhibitors, is relatively gentle. And so when you have, that's a situation where I think you want to err on the side of treating more, because I'm much more afraid of the cancer than I am of the treatment. In terms of the question that was asked about duration of response, I actually don't know the answer to what's being done on those trials. In terms of what optimal duration of treatment should be, either for metastatic cancer or for adjuvant, we don't have an answer to that, and it's an area of very unmet need. We can speculate, and there is some information available to help us to speculate. One is that in the early ipilimumab trials in melanoma, there were patients who came off of treatment after just a treatment or two to go on hospice who later had fairly durable control, giving us a hint of principle that we may not need huge duration of therapy with immunotherapeutics to achieve benefit. We can also look at the median time to response in the lung cancer trials, which seems to be about 10 weeks, giving us a hint that we may have achieved a lot of our benefit by that time point, but it's really going to take a lot of study on duration of treatments to have a legitimate answer to the question.
One point I would just make is that even with adjuvant chemotherapy, which admittedly has a rather marginal benefit, less than we would hope to have, that is for a fixed duration of time. And if it were 2 years of ongoing therapy, admittedly with more toxicity in that setting, it would be a different proposition. And so that's where I think it's really helpful if we get to the point, and I hope we do in a few years, where we have a much better idea of who's really benefiting the most. It'd be nice to be able to enrich for that, because we are certainly obligating people to the potential toxicity, the longitudinal medicalization of their treatment, which is something you brought up before, having people come in for infusions every 2 or 3 weeks beyond the time of their surgery. We don't know how long, and we don't know if they were cured at the time of their surgery. So these are issues that we're going to struggle with for a while, but these, we can all agree, big promise, but still early days. Not surprisingly, as we talk about the enthusiasm around these drugs, some people are asking about pursuing these outside of a trial. So what do you say now about pursuing one of these agents that may be approved in melanoma now in a setting after progression, and B, if we have an approval for, say, nivolumab in a year in the second-line setting, bringing that earlier to potentially preclude chemotherapy at all?
So I think, at this point, there are a lot of issues with that. Perhaps the biggest obstacle to doing that is practical. These drugs are extraordinarily expensive, and I'd be shocked if insurance allows off-label use for lung cancer patients of pembrolizumab, the one FDA-approved drug. My other answer is that, if a clinical trial is available at all near you, I would beg you to first try to do that, because we really do need these answers on behalf of future patients.
I'd agree. I think the off-label use, will ultimately become inevitable, and helping to try and do that safe will be important. The clinical trials are critical to do better. If we stop now, if we stop the robust clinical trial infrastructure, we won't have the opportunity to do better than we are right now. So this is going to be an important part of our future. The clinical trials are necessary in order to do better.
I agree with that. I really think that one key point is that these drugs being commercially available should not short-circuit all the potential progress we still need to make about learning how best to use them. That practically speaking, it's not likely that drugs that cost $140,000 or $50,000 a year are going to be offered outside of the indications where they are approved. And so, but besides that, there's still a lot to learn. And frankly, one of the challenges that I think you faced is just showing the whole range of studies that's out there, and that's only a fraction of what's being discussed right now that still has not been publicly announced. And the various companies are falling over themselves to offer these trials in basically every setting they can find, which is good for patients. One of the other questions we have, how do you find a clinical trial? And perhaps on a related point, is there a best drug to be looking for if you have an embarrassment of riches and one or more of these immune checkpoint inhibitors? Besides clinicaltrials.gov, which has a user interface that is a form of torture. I don't know if you have thoughts on finding clinical trials and and picking among choices.
So I think there are two very good ways to do that. For those, and it's probably enriched in this audience since it's a Cancer Grace Forum, who really like to be on computers. In addition to clinicaltrials.gov, there are a number of advocacy organizations that offer trial engines that are supposed to be easier. Lung Cancer Initiative of North Carolina offers one. National Lung Cancer Partnership offers one, and I'm sure that there are other excellent ones out there that I'm just less aware of. The other is to go get a consult from somebody who does lung cancer for a living. It's part of our job, those of us who do a lot of consultations as second opinions, to say what clinical trials we have available, and to also be aware of clinical trials happening elsewhere, and to do searches on behalf of patients. And so I think a good second opinion doc does this routinely as a part of practice.
Other thoughts?
I agree, particularly with the latter point, which is that use your doctor. They're meant to be your guide and your quarterback in therapy, and ask. I think that they're important parts of your treatment. I
would say that all makes good sense. That I think it's more realistic to think that somebody who has a specialization in lung cancer or whatever cancer you're focusing on will have a better command of the array of leading trials than somebody who's treating 15 different cancers over the course of the day. It's just too much, really. But also that these online, there's a lot of people talking about them, and that, yes, there are organizations that are well aware of the challenges in finding trials and do have trial matching services to help work through the eligibility requirements. One of the other questions people asked was, which of these trials is available first or second or later lines? And the answer is they're they're varied from one trial to the next. They have different requirements for Pdl-1 expression or not, for what line of therapy and what prior therapies people have received. So these are going to vary from one trial to the next, and that might be a big factor in terms of selecting what would be the best trial for you, is that you might be not eligible for one that requires a certain level of Pdl-1 expression, but there's others that don't have that restriction.
I think I'd add too that if the first trial isn't available either because of eligibility or specifics or nature of that trial, or because it doesn't work for you in terms of convenience, don't despair. I think that there's such a plethora of these trials that are being used in a variety of settings that if you choose a different type of treatment, whether that's chemotherapy or a clinical trial of a different sort, in the beginning, I suspect that there'll remain opportunities to use these therapies other times.
You mentioned neoadjuvant or preoperative therapy as a model, and there's one or two trials out there. Is that something you think is a uniquely attractive approach in terms of learning about the biology, or is that potentially too short a window to tell us what we want to know?
My sense is that it's a hugely valuable opportunity. I think many of these trials, and some of you who have been on these trials have known where there's requests for biopsies in the beginning, perhaps even on treatment. And that tissue has been so incredibly helpful to try and better understand why is someone responding, what predictors are there for response. That's how we ever got to Pdl-1 as a potential biomarker in the first place, with the problems with that notwithstanding. But the tissue that we get is often very small. And to be able to really truly answer some of these questions, the opportunity to have a substantial amount of tumor tissue along with lymph nodes and blood is incredibly important from the scientific side to better understand why these are working, how these are working, what does this look like. The neoadjuvant setting, I think, piggybacks on what would otherwise normally happen, which is that you get some treatment before surgery, and then you have surgery. It's surgery that would otherwise be indicated for you anyways. And that tumor tissue can be just a remarkable resource afterwards to try and understand how this works. And so I think that setting in particular is incredibly valuable.
I couldn't agree more from the scientific perspective that this is the right approach. I also think it's a very promising approach from the selfish perspective. And these ideally should merge together, right? If we're all doing our work ethically and right, they should both be there. If we ask ourselves about why don't we cure everyone with lung cancer? In my opinion, the greatest answer to that is that there's micrometastatic disease. So meaning that at diagnosis, there's cancer too small to see on a CAT scan or a PET scan that's already spread, and that our chemo just isn't good enough at cleaning that up. If you look at the history of immunotherapeutics, and most of that history goes back to melanoma and renal cell carcinoma over decades, it seems to work best in patients with minimal disease. And so these treatments may be really good at eradicating micrometastatic disease. There's existing reasons to be hopeful that that might be true. And so I think that adding immunotherapy of this type to attempts at cure may be one promising way to overcome the micrometastatic disease problem.
One thing I think is going to be very useful about neoadjuvant therapy is the question we still have about pseudoprogression and what's happening when a tumor enlarges. I think that's going to be a cause of some concern when 6 weeks in you see something enlarge, and is this disease progressing, and failed neoadjuvant therapy, which is the biggest concern about it, is that the cancer will progress on it. But having patients go on to surgery, resect that, see what was actually happening, is going to be something we are going to learn much more about in that setting than the very selective sampling we're doing otherwise in the more metastatic disease setting.
I think one thing I'd add just about pseudoprogression is at least I think the experience is an incredibly important concept, the idea that the cancer can grow, at least radiographically, without it being a sign that the medicine's not working. But it also doesn't happen that often. Mm-hmm. And I think that recently there's been such a focus on pseudoprogression that I think that the narrative has become just keep going because it could be pseudoprogression. And I think the pendulum has to move back a little bit further towards talk to the patient. If you're not feeling well, if you're not feeling better, it's probably a sign it's not working. And so I think that what it looks like on a CT scan has to be put in the context of what the patient is feeling. And usually pseudoprogression, if it is actually happening, is happening at the same time as the patient feeling better. And when they're not feeling better, you often have to stop.
Great point, because I am concerned that the message is, if the cancer's shrinking, stay on the drug. If the cancer's looking worse, stay on the drug.
Yeah.
That is not necessarily the nuanced answer we want to have. People are asking about Pdl-1 expression, and a few general questions. One, can it be done from pleural effusion cytology, from a block, or does it need to be from a biopsy? Second, should we be doing it at all? And how good is the correlation of that with outcomes in the setting of lung cancer, as a just general broad strokes? I know we're going to talk a little about this in this afternoon session, but I'm not sure how much of it's going to be lung specific. So I'll start with you, Matt.
Sure. So I guess I should say that this is a personal opinion alert, because there's no right answer. I think it has some value, but I don't think that the marker is good enough that it'll be the biomarker for deciding therapy. I would actually be somewhat surprised if it's routinely used several years from now. I think the testing itself is difficult and unreliable, and each assay is different. It also requires specific types of tissue. So in terms of the question of pleural fluid, it probably doesn't work in pleural fluid.
Bone would be
Bone, it doesn't work. So there are a lot of settings in which it's not accessible. But I think the one place in which it really can be useful is either potentially in a neoadjuvant setting or the first-line chemotherapy setting. Because when you see somebody who has potentially resectable lung cancers, you want to give them some reasonable confidence that that medicine can work. Otherwise, you're giving them several weeks of delay without any potential benefit. And if Pdl-1 isn't perfect, it does at least enrich for the response up to 30 to 40%. And that's a pretty reasonable fraction. And that's a group of people who you might feel confident to say, this is a medicine that I think can help you. And if it does help you, it's a profound benefit. And the same setting is true in the first-line chemotherapy setting, in which chemotherapy works, but it only works in, say, 30 to 40% of people. But if Pdl-1 drugs work in 30 to 40% of people with Pdl-1 positive cancers, then that's a reasonable idea. So I think that for patients that have either a good alternative that has a reasonable response, Pdl-1 is a useful way of deciding what's the next best thing. I think beyond the first-line setting, Pdl-1 probably doesn't have an important role.
Other thoughts, Jared?
I actually entirely agree with all of that, and I think you have a big enough stack that...
Well, actually, we'll have to not go through all of them, but divide and conquer during the break. I would just add one other thought that, and you alluded to this, that I believe the threshold needs to be different between first line and later lines. That I was involved in a meeting last week where I had the, quote, curmudgeon role in a debate that we should not be integrating these therapies first line or replacing first line chemotherapy if these drugs are approved one or more in the later line setting. I think we have already been down this road with the trial called IPASS several years ago, which was really a watershed event or watershed presentation that was a clinical selection of Asian never smokers with an adenocarcinoma, 94% never smokers. That was a group of patients who was meant to be the cue that, oh, we're talking about people who are extremely likely to respond to EGFR inhibitors just before mutation testing became very widespread. But the trial actually showed that, first of all, 60% or only 60% of those patients had a mutation, which is more than you'd expect to see, but it's not 100%. And if you were in the 40% that didn't have the mutation, you did clearly better by getting first-line chemotherapy rather than the new, sexier targeted therapy. And I think that's very instructive in this setting where we have a treatment that has a low but real response rate and major benefit for a subset of patients, that is enriched by a biomarker that is not as reliable as EGFR mutation, but that we'd hate to restrict based on that because it's not it's not necessary for that. But to replace the standard treatment, I think you need to show that you're better than that with some confidence, and I don't think that's been achieved yet.
Yeah, I think when we start, though, I agree with all that, but when we get to second and third line, I think what's happening in clinical trials right now and what I'm likely to do in practice, if able to, is probably going to diverge some. So I entirely agree for first line. When you get to later lines of therapy, Pdl-1 expression seems to predict for greater efficacy of these drugs to different extents in different trials. Where I start to have trouble with the way the trials are being run is that there's a real rate of response in later line therapy for Pdl-1 negative. And these trials are, for the most part, excluding Pdl-1 negative patients, where in clinical practice there may be real reason to think that there's benefit there.
Great. Well, thank you both so much. We have a brief break before we reconvene for the general session, so feel free to find any of us. Great.